Hello, my name is Sanam Loghavi. I'm a hematopathologist and a molecular pathologist at MD Anderson Cancer Center, and I'm here to discuss with you the results for the poll that was posted on the Twitter account of the Journal of Immunotherapy and Precision Oncology last week. You may recall that we had posted a poll showing the images of the bone marrow biopsy and the bone marrow aspirate smear as shown here from a 35-year-old man with leukocytosis and monocytosis and eosinophilia. The routine karyotype performed on this bone marrow biopsy had shown a translocation 512, and we asked you what the next steps for confirming the diagnosis were. And as the majority of you have answered correctly, the next step for the confirmation of this diagnosis is to perform fluorescence in situ hybridization, or FISH, to detect a rearrangement involving PDGFR beta. And the reason for that is that PDGFR beta localizes to the long arm of chromosome 5, the 5q32 region. These neoplasms typically present with very hypercellular bone marrow that shows eosinophilia and is often associated with monocytosis, as shown in this case. The first answer, FISH for BCR-ABL1, is incorrect because, as you know, BCR-ABL1 shows as a translocation involving chromosomes 9 and 22 on a routine karyotype. FISH for deletion of CHEK2 is actually used to diagnose myeloid neoplasms or myeloid and lymphoid neoplasms with PDGFR alpha rearrangements. PDGFR alpha rearrangements are typically cryptic, meaning they are not seen on a routine karyotype, and so you either have to perform FISH to detect the deletion of CHEK2, which leads to a rearrangement of PDGFR alpha, or to use PCR. PDGFR alpha rearranged cases are also associated with eosinophilia. However, unlike PDGFR beta rearranged myeloid or lymphoid neoplasms, these typically do not show monocytosis, and they are associated usually with abnormal mast cell proliferations, which can also be seen in cases of PDGFR beta rearrangement. And finally, PCR for inversion 16 is incorrect. Because of the findings of the routine karyotype in this case, but it's important to keep in mind that cases of AML with inversion 16 are also typically associated with monocytosis. So it's good to keep this in mind as a differential diagnosis. But again, with the karyotypic abnormality shown in this case, the correct answer is fluorescence in situ hybridization for PDGFR beta rearrangement. And the reason that recognition of these cases is important is that these neoplasms are highly sensitive to tyrosine kinase inhibitors, such as imatinib, and can essentially be very successfully treated using these agents. So it's important to appropriately identify and diagnose these cases so that the patients can be appropriately treated. Thank you for your attention.